My name's Neil Hershen, Communications Manager here at JLA, and I'm delighted to be your host. Thank you for taking the time to join us. We're really pleased to have you with us for what promises to be an insightful and practical discussion on one of the most critical challenges facing healthcare today, infection prevention and control. At JLA, we work closely with NHS trusts and healthcare providers across the UK, so we see firsthand how vital effective infection control is, not only for compliance and operational performance, but for patient safety, staff well-being, and long-term sustainability. We're joined today by two experts on this topic. First, Professor Katie Laird, Professor of Microbiology at De Montfort University and Deputy Director of the Leicester Institute for Pharmaceutical and Health Innovations. Katie is a leading expert in microbiology and infection prevention, and her work has significantly advanced our understanding of how pathogens survive and behave within healthcare environments. She'll be sharing groundbreaking research revealing just how resilient microbes, particularly C. difficile spores, can be on healthcare textiles and challenging some of our long-held assumptions. We'll then hear from Lucy Cripwell, JLA's in-house chemist. With a degree in forensic science and over 5 years' experience in research and development, Lucy focuses on creative, innovative, sustainable laundry solutions that boost efficiency, reduce environmental impact, and help healthcare environments meet strict infection control regulations. Lucy will bring the science to life by exploring how reusable textiles, on-site laundry design, and compliant disinfection processes can support safer patient care and reduce infection risks across the NHS. Whether you work in clinical settings, facilities, IPC, procurement, or service delivery, this is an important session for anyone shaping safer, smarter healthcare environments. So with that, to begin with, I'll hand over to Professor Katie.
Thank you, Neil, for that introduction, and thank you to JLA for inviting me to speak on this webinar. So today we're going to look at the research that we've been conducting within our group on C. difficile spores and how they're able to survive through laundering processes, but also the survival of bacteria on textiles and how those microorganisms shed from uniforms, particularly we're going to look at. We're also going to discuss the efficacy of domestic washing machines in laundering of healthcare uniforms and what their contribution is to antibiotic resistance. So firstly, for those of you that are not so aware of what C. difficile is, it's a gram-positive rod that grows in anaerobic environments, so that's with limited oxygen. But what's key about the transmission of C. difficile is that it's spore-bearing, and it's those spores that allow the C. difficile to stay in the environment for so long. It produces a range of toxins, which is what induces that really horrific symptoms to the patients and those diarrheal symptoms. It's usually hospital acquired, so it's in the more elderly patients that have been on courses of antibiotics and their gut microflora has gone, and then C. difficile has colonized that gut. So the exposure to antibiotic therapy is really key when we're talking about the infections of C. difficile. So why are the spores so hardy and of concern? Well, the spores themselves have got a really tough outer coat, a really tough outer protein coat, and they withstand high temperatures, desiccation, disinfectants, so they're able to just survive in the environment for actually years. And it's this ability to survive and resist things that makes them so difficult to remove from the healthcare environment. So what we've looked at is these spore survival through wash systems. And what we did was we did a simulated wash at 71 degrees for 3 minutes, and we inoculated some textiles. And within the wash, we put a sterile swatch as well, so we could see how those spores were transferring around the wash. And we did this with the type strains, so they're the strains of the C. difficile that we have within the lab. But we also took a ribotype from the hospital environment, so we were looking at a strain that had come actually out of the hospital. So what you can see here is the dark black bars were the initial inoculum that we put in. The grey is a swatch that was previously sterile, so we are seeing some moving around of those spores within the wash. They're just being lifted and distributed to other bits of textile. We're looking at recovery after laundering, so you can see there with and without detergent. And what you can see in the white bars where there's no detergent present is that you're getting a lot of survival and on the original swatch, but also transfer to sterile swatches within the wash. When you add the detergent, this is significantly reduced. So the detergent is absolutely key in reducing C. difficile. Now, you may look at this graph and think, well, there's hardly anything left. What's the issue? But the known dose to cause infection in C. difficile is not known, but it is thought to be, it could be as low as 6 spores. So when you put that into context, even though those bars are very small, there is still a chance of infection. What we also managed to do was look at the spores in these high temperature washes and how they were distributed onto the actual textiles. So what you can see here is we managed to get, the machine actually broke down, so we were able to get the swatches out part way through the wash as well, is that we were able to actually see the C. difficile spores on the textile and how they're embedded into the fibres. Now, in panel C, where there's a white arrow, what you can actually see there is we believe there is some type of attachment occurring, so that they're actually attaching to the textiles. But what you can also see is a lot of spores clumped within the fibres. So this just shows how the C. difficile is attaching and is still attached during wash processes. So to understand that attachment and understand why the disinfectants are working and how the wash process is able to decontaminate, we needed to understand how it was actually performing from ward to washer rather than just in the lab. So what we did was we set up a study whereby the C. difficile ward in a particular hospital was using blue bed sheets, and they were isolating these bed sheets after they'd been soiled in the area outside where the linen is collected for us to take. So we were getting samples straight from the patient's bed. We take them to the lab, we'd mark where the soiled area was, and we'd establish how many spores were on that textile. So here you can see pre-wash, there's 51 spores per 25 centimetre squared, and what ribotype that was. So we understood, and this was actually the first time we understood what amount of spores was being shed onto the textiles. We then took those sheets to an industrial laundress, and because we'd marked the area, when they come out of the laundry, we could resample in the area that we knew was soiled. And what we were actually seeing was that there was still 33 spores remaining in the 25 centimetre squared area. So it was showing that these industrial washes were not removing the C. difficile spores. And again, we could look at them under the microscope. So it's a large SEM, so a scanning electron microscope, and we could still see that the spores were there, very similar to the first images that we showed you, which were more out of lab-based samples. So why are they attaching so well? And understanding how the spores attach will give us some insight into how to remove them. So what we did was started to look at how we remove that tough outer coat, the exosporium that I mentioned earlier on in the presentation. So we treated them with just butter that does nothing. We treated them with trypsin that takes partial removal of that protein coat. And then we treated them with proteinase K that removes it all. And we looked at their attachment over a period of time. and we also looked at the hydrophobicity. And what you can see there is that the more you remove the coat, the less the outer coats, the proteinase K, the less attachment you're seeing, but also you're significantly reducing that hydrophobicity. So this really shows that those disinfectants that have sporicidal activity really need to be damaging that outer coat of the spores to prevent them from attaching and thus making removal easier. And what you can see here in these images with the white arrows, particularly in panel B and D, where the wall is, that we're seeing some type of almost like finger-like projections coming out of those spores and attaching to the fabric. Now, this has also been shown on agar plates and in glass slides that the spores are trying to attach themselves to. So although these images are not absolute, this is what's happening, it does give us some indication of how we think the spores are attaching, why they're attaching so well. So next we're going to look at the shedding of microorganisms from uniforms, because it's okay to say that microorganisms are on the uniform, but are they a transmission risk? And when we move with these contaminated textiles on, is there a chance of infection? So what we've got here is an image of something called a body box, which is basically a large sealed box with an air capacity of just over 3,500 litres of air. And what it does, it contains the air within that environment that you're able to sample. And what we did was we had a volunteer go into the body box and do some exercise whilst contaminated with the microorganisms to see what was shedding. So we took a healthcare uniform and we inoculated different areas, the arms, the chest, the legs and the groin areas. And we used a range of different microorganisms. You'll be pleased to know they're all class 1, so they couldn't infect the individual that was doing the experiment in the box with us. But we had an E. coli strain, Saccharomyces cerevisiae, which was there to represent sort of the Candida auris. We had a non-pathogenic Staphylococcus and a non-pathogenic Bacillus spores. So we could really look at how the uniforms were being contaminated and then potentially shedding. So the individuals had a hairnet on, full clean room, overalls underneath the uniforms, shoe covers and masks. So we were really limiting the contamination that was shedding from the individual. So here you can see the piece of kit in real form. And what you can also see there is where we put all the different air samplers. And you can also see the sticky mats that you have to walk over to go into the box to remove any contamination from the feet as well. So we had an external air sampler on the outside, and we also had an air sampler within there as well. And where total sampling was 4,000 litres of air, so we knew that we were sampling all the air from within the box. And what you can see here is pre-laundering after contamination, we were getting shedding. The groin area, we only focused on Staphylococcus, but all the other areas you can see a reasonable amount of shedding from the E. coli, the Staphylococcus, and from the yeast. But what we were seeing was that the arms and legs area was where shedding was occurring most, and we think that relates to where the most movement is. You can also see the control, which is showing that there was some natural shedding from the person and the textiles within the box, and this was about the same as the chest, so we don't think that there was much shedding happening from the chest areas. But anything above those levels we know was the organisms that we put onto the uniforms. But what we also did was we laundered the items, and we repeated the experiment to see if there was still shedding. We didn't focus on the groin because this was a particular different audience. But what we definitely saw that there was still shedding from the arms and legs, even after post-laundering, with a low amount of the microorganisms on the textiles. So in the UK and the USA, domestic laundering is used for healthcare uniforms, and as we've shown, spores are able to survive industrial laundering, and we know that the uniforms are able to shed, and even after domestic laundering are shedding. So how effective is domestic laundering as an infection control measure? Well, what we saw when we look at survival on textiles generally, we've got the green and the blue dots, which are cotton samples, and the red and purple that polyester, and then we've got Staphylococcus and E. coli on them, is that the survival of these organisms is happening over a number of days and is able to survive. And in the case of the cottons, is actually over quite a few weeks, so up to 21 days. And the cotton, we believe, is able to retain the bacteria more because obviously it's not a smooth fibre, it retains some moisture, and there would be some nutrients in it, unlike the polyester was seeing a drop off within a few days. So we also looked under the SEM and looked at the survival of microorganisms on these different fibre types. And what you can see is on the polyester, the microorganisms are very spread across it, are not clumped, and they're very much on the surface. Whereas you look at the cottons, what you can actually see is much more clumping of the microorganisms and within the fibres. So it really shows you where these microorganisms are. And research we've done since this on a number of different surfaces shows that the shedding from polyester is much greater because it just easily comes off the surface than that of the cotton. So we did look at 40-degree washes, and again we put some sterile swatches in, and this was for E. coli and Staphylococcus. And we looked at 40-degree wash with detergent and what was happening. And what we basically saw was that both microorganisms were not being significantly reduced, and they were just being moved around the wash. So 40-degree wash, as would be expected, is absolutely not effective as an infection control process. Now, guidelines state that you should wash at 60 degrees your uniforms at home, but with costs associated with this, the move towards more eco washes, etc., you can't guarantee that all healthcare uniforms are being washed at those higher 60 degrees. So you don't just need to take my word for this. There's been a number of published studies showing that a range of microorganisms survive on a range of different textiles, and this includes bacteria, yeasts, and viruses. So this has been well published over recent years. And also there is a number of published studies showing that textiles are able to transfer microorganisms onto a range of different surfaces. And again, it's spores, it's bacteria, and looking at a whole range of different textiles and surfaces, such as fingertips, skin, from stainless steel and vinyl. So the next part of the study was to truly understand what was happening within domestic laundering of textiles. So what you can see here on the image on the left-hand side is a bioindicator that contains Enterococcus, which is a thermotolerant bacteria, and we've got it at all different concentrations from 3 logs to 6 logs, and it's gone into a 60-degree machine. So this is the recommended temperature for healthcare uniforms at home. We looked at full length and rapid washes, and we looked at biological and non-biological detergent. We tested this in a number of machines, so different makes and models and different ages, to look at how they were behaving within disinfecting the textiles. So first of all, we'll focus on the full length cycle, and what you can see is that the holding time for 3 of the machines was over the recommended 10 minutes. So there was only 3 machines out of the 6 we tested that were actually reaching temperature. So there were 58, so not quite 60, but 58, 57, and holding for the 10 minutes plus. Now, unfortunately, machine 6 never went above 20 degrees, and the gentleman in the lab whose machine it is thought that it was performing as it should be and had been washing using this machine for a number of years, but actually went and bought a new one after this research was conducted. So even in a small sample of machines, we're seeing 50% are not reaching the temperature and holding time required. And this only gets worse when we look at either rapid cycles or those eco cycles. We're only then seeing 2 machines that reach temperature and time, and the rest have all failed. So we were definitely seeing a correlation between the age of the machine. So anything over 4 years started to decline in its performance. But what does this mean for infection control? Well, we put the bioindicators into all these washes, and as you can see here, machine 1 and machine 6 completely failed. They were unable to decontaminate the bioindicators. Now, obviously, if these were healthcare workers' machines at home, they would be doing everything they were meant to be doing, but absolutely not decontaminating the uniforms. When we look at machines 2 to 5, we can see that more of them passed. However, there is a cluster in those more rapid washes that still don't decontaminate. So this is not a good picture. So if you think about the size of the sample here and then that multiplying up to the number of nurses in the UK, a significant amount won't necessarily be washing at 60, and then those that do wash at 60, around 50%, won't actually be decontaminating their tech uniforms. We also looked at what bacteria were found within those domestic washing machines, and we looked at the pipe where the detergent goes in, but also the rubber seal around the machine. And as you can see from these images here, it's hosting a whole array of different bacteria. So it's got its own microbiome in the machine. And this is only the 10 of the most abundant different bacteria. There were many more. And what we also looked at was if there was any antibiotic resistant genes within those machines, and we did find them. So again, here's the 10 most frequently found ones, and what you were seeing were most of these were in the form of efflux pumps. So this is where the bacteria just pumps out the antibiotic, and you can also see there that some of the genes isolated were actually those that were known to be resistant to disinfectants, which makes sense because they're within a washing machine where there is a lot of disinfectant presence. So what we wanted to understand next was whether the detergent and disinfectant were actually causing cross resistance to antibiotics, which is really important when we're thinking about those uniforms going back into a healthcare environment. So what you can see here is an outline of how we did the experiment, but basically we took the detergents that were used in a domestic machine. So this was a non-bio because the enzymes would confuse matters a little bit. So we took a non-bio and we subjected it to a sublethal dose of the detergent. So if you think about your washing machine, can you tell me how much water is in your machine? Can you tell me how heavy a load you're putting in? And can you tell me what amount of detergent is needed for every wash based on these factors? I'm not sure anyone would answer yes to that because we just don't know. That information isn't given to us in a domestic machine, whereas it would be monitored and validated with the industrial machine. So what we did was we took the detergent and subjected the bacteria to a concentration that was 80% growth would be allowed. And we then, once the bacteria had survived this, we increased that dose a little bit and waited 24 hours. And again, when the bacteria had survived, we kept doing this over 20 passages. So we were training the bacteria to be resistant to the domestic detergent. Now, if you think about how much detergent we put in, we can be quite often underdosing. So it was trying to mimic what could be happening in the machine. And what we saw was the 3 bacteria that we tested, the Staphylococcus, the Klebsiella and the Pseudomonas, we were able to increase the tolerance to those detergents, well, in both powder and liquid forms by significant amounts. If you look there, it's a greater than 1.5 million fold for the Klebsiella. We then exposed the bacteria to antibiotics that they had never been in contact before. And what you're seeing is the zone of inhibition, so the inhibition of growth with the blue dot before exposure to the detergent. And then the orange dot is after those 20 passages of exposure. The green bars are where you see that the bacteria are susceptible to the antibiotic, and the orange bars are where they've gained resistance to the antibiotic. The white in the area is like an intermediate. So what we're seeing here with the Pseudomonas is a definite shift towards more resistance to the antibiotics. Although we get no single bacteria that's gone from susceptible to resistant in Pseudomonas, we are seeing a shift in that direction. However, when we get to Klebsiella, we are definitely seeing that some exposure to the disinfectant has then shifted the bacteria into a resistant state. So this happens more in the powder one, where you can see the tertenopine and the meropenemine, you can see has gone from susceptible to antibiotics. It's only come into exposure with the disinfectant for the domestic machine, and then they are resistant to the antibiotics. Now, if we look at Staphylococcus, this happens much more frequently. You can see a number of shifts from susceptibility to resistant. And actually what we were seeing was that this Staphylococcus aureus had gone from a methicillin resistant strain to an MRSA, and it had never been in contact with an antibiotics, which is really worrying. So we have published this research if you're interested in it, so you can find it here. And within that paper, we did put some recommendations. So we don't recommend that healthcare workers use short cycles. We have to rely on thermal killing. So actually the temperature needs to be 70 degrees is more effective than sort of 60 for 10, but then often the textiles can't withstand that. They need to clean their domestic machines regularly. They mustn't mix laundering, and every 4 years actually we'd recommend a new machine because they stop performing. So recommenders for the employer would be that they supply the detergents, they offer servicing and performance monitoring for domestic laundry machines, that actually more preferably that they have an on-premises laundry or they outsource to a commercial laundry. These are really important so we can ensure that our healthcare workers' uniforms are definitely not contaminated. So in conclusion, spores are able to survive domestic and industrial laundering. Microorganisms can readily survive on textiles and are able to transfer from those uniforms and shed into the environment. that actually our domestic washing machines at home harbour antibiotic resistant genes, and sublethal dose of domestic detergents can actually cause cross-resistant to antibiotics. And this is particularly pertinent if it's on a healthcare worker's uniform, because they'll be going back into that healthcare environment. So some acknowledgements here. I'd like to thank the Infectious Disease Research Group, who have all contributed to this research.
Thank you for that, Professor Katie. Let's hand over now to Lucy Cripwell, who will be talking about putting the science into practice. Over to you, Lucy.
Thank you, Neil. I'm really pleased for the opportunity to speak today. My name is Lucy Cripwell, and I'm the Research and Development Chemist at JLA. Today, I'm going to talk about the growing shift towards reusable medical textiles within the NHS, why the shift is happening, what's driving it, and what it means in practice. I want to focus on the implications for laundry services, because that's where many of the real risks and opportunities sit. Laundry is often viewed as a background function, something that just happens. It's rarely discussed unless there's a problem, an outbreak, or a failure. But as we move towards more sustainable models of care and increased reuse of textiles, laundry becomes a critical control point. It directly influences patient safety, staff well-being, environmental impact, and cost. So today, my aim is to reframe laundry, not as a support service on the periphery, but as a core infection prevention process that must evolve alongside reusable textiles if we want this transition to be safe, credible, and successful. To understand why this conversation matters, it's worth taking a look at the scale of the issue. Each year in the UK, approximately 55,000 tonnes of medical textiles, including single-use PPE, are incinerated. This represents a significant environmental burden and highlights the scale of waste generated by disposable healthcare products. The COVID-19 pandemic brought into clear focus the fragility of global supply chains when it came to PPE. National shortages of products led to critical PPE becoming inaccessible. This experience, combined with the NHS's commitment to achieving net zero, have accelerated interest in reusable alternatives as a way to regain control, reduce waste, and improve long-term resilience. A 2021 study identified surgical gowns as being one of the most carbon-intensive PPE items used in healthcare, which prompted several NHS trusts to trial reusable options. The outcomes were compelling. Switching from disposable to reusable surgical gowns could reduce solid waste generation by up to 84% and cut greenhouse gas emissions by up to 66%. In addition to the environmental benefits, evidence showed that reusable gowns outperform single-use products in key safety test areas, and by switching to reusable, NHS England case studies demonstrated cost savings of around 45%, reinforcing that safety, sustainability, and financial efficiency can go hand in hand. Despite this strong evidence, uptake remains low. In 2024, it was reported that only 30% of the NHS estate had implemented reusable surgical gowns, meaning 70% still rely on single-use products, indicating significant opportunity for further progress. Reusable textiles don't just exist in isolation. Every reusable item must be collected, handled, transported, washed, disinfected, dried, stored, and redistributed, repeatedly, reliably, and safely. In other words, an increase in reusable textiles inevitably places a greater demand on laundry services. For many trusts, outsourcing linen for processing appears to be the only viable option, particularly for high-volume items like bedding, which require specialist industrial equipment and infrastructure. However, outsourcing is not without its challenges. It is estimated that 4 million pieces of linen are lost each year, equating to over 80% of the total linen in circulation. These losses are attributed to factors such as misuse, mishandling, theft, inadequate tracking systems, and logistical failures. The environmental impact of this is substantial. This lost linen equates to around 7,600 tonnes of carbon, and to remanufacture it would require approximately 24 billion litres of water. So, there's an uncomfortable reality here. Without effective linen management and laundering systems, reusable textiles could quietly undermine the very sustainability benefits they're intended to deliver. When we talk about laundry models within the NHS, there are generally three approaches: fully outsourced, fully in-house, or a hybrid of the two. Outsourcing involves transporting linen to external industrial facilities who provide a laundry service. In-house laundry, by contrast, refers to facilities located within the hospital grounds and staffed by the trust or by their appointed facilities management provider, sometimes serving multiple hospitals. Hybrid models encompass both, by laundering some items externally and some items internally. For most trusts, bringing all laundry services in-house isn't realistic. Space constraints, capital costs, and infrastructure requirements would often make this impractical. But this doesn't mean outsourcing everything is the only option. There are successful examples of in-house laundry facilities across the NHS, delivering significant benefits. Nottingham University Hospital's NHS Trust operates a large-scale, purpose-built, on-site laundry processing 40,000 bedsheets per day, alongside curtains, towels, and blankets. The image you can see on screen is actually taken from their facility, demonstrating just how vast their operation is. At the other end of the scale, Royal Cornwall Hospital, for example, runs a smaller facility, focusing on items such as slide sheets, neonatal garments, and microfiber mops. These smaller, targeted, in-house laundries with a hybrid approach are more common and often deliver strong benefits. Where feasible, bringing selected services in-house offers advantages including cost savings, reduced turnaround times, and improved process control, thereby reducing linen loss. One example of this to highlight that we know of is a trust that brought their mops laundering in-house after spending £80,000 a year replacing mop heads lost by an external provider. In-house facilities also enable healthcare uniforms to be laundered safely on-site, reducing the risks associated with laundering them in domestic machines, highlighted earlier by Professor Katie Laird. Regardless of whether laundry is processed in-house or outsourced, robust infection control procedures are essential. The impact of inadequately disinfected laundry is often underestimated, yet contaminated textiles have been directly linked to numerous healthcare-associated outbreaks. Examples of documented outbreaks associated with mucormycosis, Clostridium difficile, and Bacillus cereus demonstrate that linen can act as a vector for pathogen transmission if controls fail. The key message here is straightforward, but often overlooked. Laundry is not a low-risk service. It is a process that requires the same level of governance, validation, and scrutiny as other IPC critical systems, and this is why standards, infrastructure, and assurance matter. So, having established that laundry is a critical infection prevention function, the obvious next question is, what does good actually look like? Health Technical Memorandum, or HTM 0104, provides national guidance on the safe handling, processing, and storage of healthcare linen. It sets expectations not just for washing, but for the entire processing cycle of healthcare textiles. The laundry process begins outside the laundry room with correct classification and segregation. If linen is incorrectly classified at the point of use, the rest of the process is put at risk. Infectious linen must be placed in red water-soluble bags, designed to be put directly into the washing machine without being opened. While the HTM provides a national baseline of what should be classed as infectious, local policy often introduces additional controls based on risk assessments, for example, specific organisms, wards, or patient groups. Once inside the laundry, maintaining strict dirty to clean segregation is essential to reduce cross-contamination. This can be achieved through a one-way workflow where linen physically moves in a single direction from dirty receipt through washing to clean drying and finishing. Another method, and preferred option where feasible, is the use of barrier washer systems. Barrier washers are dual access machines with one door opening into the dirty area and the other into the clean area. This creates a physical barrier between contaminated and clean environments. When the laundry is placed inside of the washing machine, it is vital that a robust and reliable disinfection process is used. There are three categories of disinfection used in healthcare laundering, each with advantages and limitations. The first is thermal disinfection, which relies on a time-temperature relationship of either 65 degrees Celsius for 18 minutes or 71 degrees Celsius for 11 minutes, including the mandatory mixing time to allow for heat penetration of the full load. The second are chemothermal processes, which use chemical disinfectants that require heat to become effective. And thirdly, chemical-only disinfection, which relies on chemical agents that do not have a temperature dependency. Thermal disinfection has traditionally been viewed as robust and reliable. However, research has shown that some organisms, including spore-forming bacteria such as Clostridium difficile, can survive these conditions. High temperatures also accelerate fabric degradation, are unsuitable for heat-sensitive textiles, and are energy-intensive, making them costly to operate. For any alternative disinfection method to be compliant with HTMO 104, several requirements must be met. They must be validated, having established documented evidence that the process consistently delivers adequate disinfection. They must provide real-time verification, so operators are alerted if disinfection conditions are not achieved. And they must have the disinfection efficacy equal to or exceeding thermal methods. This is demonstrated by microbiological test methodology to achieve at least a 5-log reduction of specified vegetative bacterium. Confidence in disinfection comes from being able to evidence performance, not simply assume it. Liquid chemical additives, such as chlorine bleaching agents, must be delivered via auto-dosing systems. These systems should incorporate accurate flow meters and alarms. This ensures operators are alerted if the correct dosage is not delivered, preventing silent failures, where a cycle is complete, linen looks clean, but disinfection parameters were never met. Technologies utilizing ozone are becoming increasingly common in healthcare laundry environments. Ozone has strong biocidal properties, even at low temperatures, and is suitable for a wide range of textiles, including those that are heat sensitive. These characteristics make ozone-based systems particularly attractive for supporting sustainable laundry operations without compromising infection prevention. As with any chemical system, ozone-based processes must be validated and provide real-time assurance. It is also important to be cautious with so-called bolt-on chemical systems. If washing machine cycles are not optimized for the chemistry being used, in terms of temperature or contact time, for example, disinfection efficacy may not be achieved, even if the chemical itself is effective. That's why it's important to remember that in laundry, system design matters just as much as the chemistry. Once linen has been washed and disinfected, it should be dried and finished as soon as possible to minimize the risk of recontamination. Clean linen should be transported via dedicated clean routes and then stored appropriately. Failures at this stage can undo everything that was done right earlier in the process. So to bring it all together, the 5 key steps to a compliant laundry process are: accurate classification and segregation of linen, clear separation of dirty and clean processes, ideally using barrier washers, a disinfection method that operates in line with HTM 0104 requirements, prompt drying and finishing, and secure transportation and storage along clean routes. Whether laundry services are delivered in-house, outsourced, or through a hybrid model, these principles do not change. What does change is the level of visibility and control an organisation has over them. So finally, to conclude, the transition towards reusable medical textiles presents a clear opportunity to reduce the environmental impact, improve resilience, and achieve meaningful cost savings across the NHS. However, these benefits can only be realised when reusable systems are supported by robust, well-designed laundry processes that place infection prevention at their core. Access to in-house facilities provide operational and cost benefits, but whether laundry services are delivered in-house, outsourced, or through a hybrid approach, compliance with HTM 0104, validated disinfection processes, and effective linen flow are essential. And finally, by investing in the right infrastructure, controls, and partnerships, trusts can safely support sustainability ambitions while maintaining patient safety, staff protection, and public confidence. Thank you very much for listening, and if you have any questions, then please feel free to reach out to me on LinkedIn or via email, the details for which are on screen.
That brings us to the end of our first session. On behalf of everyone at JLA, I'd like to say a huge thank you to our speakers for sharing their expertise, and thank you for joining us. We hope you're leaving with some new insight, practical ideas, and fresh perspectives that you can take back into your own organisations. You can find more resources on this page and in the description below. This includes our white paper called Healthcare Laundry and IPC Standards, Making Reusable Textiles Work Safely. There's also a free infection control guide titled What Does Best Practice in Infection Control Look Like?, which contains practical advice on reducing risk, staying compliant, and creating safer spaces for patients, staff, and visitors. And don't forget, this is just the first session in our HealthSmart series. In our second webinar, From Sustainability to Smart Systems, we'll be exploring how digital innovation and sustainable solutions are shaping the future of infection control across the NHS. This will be available on the JLA website in the coming weeks. Thanks again for joining us today, and we hope to see you in the next session.